Good evening, everyone. My name is Andra Gillespie, and on behalf of the staff and the visiting fellows of the James Weldon Johnson Institute, I'd like to welcome you to the first of our public dialogues in race and difference for the 2021-2022 academic year. Before we begin, I'd like to start by reading Emory's land acknowledgement, which was recently approved by our Board of Trustees. Emory University and JWJI acknowledge the Muskogee Creek people who lived, worked, produced knowledge on, and nurtured the land where Emory's Oxford and Atlanta campuses are now located. In 1821, 15 years before Emory's founding, the Muskogee were forced to relinquish this land. We recognize the sustained oppression, land dispossession, and involuntary removals of the Muskogee and Cherokee peoples from Georgia and the Southeast. Emory and JWJI seek to honor the Muskogee Nation and other indigenous caretakers of this land by humbly seeking knowledge of their histories and committing to respectful stewardship of the land. We're grateful to everyone who's joined us tonight. For those of you who are new to JWJI, let me tell you a little bit about what we do. The James Weldon Johnson Institute is Emory's research center dedicated to the study of race and difference. We host visiting fellowships for graduate students and recent PhDs to finish major book and dissertation projects. We also sponsor an undergraduate fellowship for honors students writing theses on topics related to race and difference. In addition to this, we host a weekly colloquium where scholars from around the country present on newly published work on race and difference, and these public dialogues where we convene expert panels of scholars to talk about an issue of contemporary importance. Tonight's theme is inspired in part by the fact that we're doing this program as a webinar. COVID-19 has upended all of our lives and hit communities of color especially hard in very different ways. But COVID wasn't the only crisis of 2020 and now 2021. Indeed, the ongoing racial reckoning that has been due since our country's founding came to a head last year and continues today. In thinking of how these two events are tied together, I think one statement in particular sums up what inspired this event. George Floyd, in addition to being a victim of police violence against Black people, had also been afflicted with COVID. So what does it mean that George Floyd had COVID? That's the theme of tonight's panel. So to that end, we have convened an all-star interdisciplinary panel of experts to discuss the issue. So joining us tonight in alphabetical order are our guests. Dr. Jason Oliver Chang is Associate Professor of History and Asian American Studies at the University of Connecticut, where he also serves as Director of the Asian and Asian American Studies Institute. He is the author of Chino, Anti-Chinese Racism in Mexico, 1880 to 1940, which was the winner of the 2017 Kuntz Prize from Pacific Historical Review. As a public servant, he sits on the Board of Education for West Hartford Public Schools, the Governor's Hate Crime Advisory Council for the state of Connecticut, and the State Historical Records and Archives Board. He's also the founding member of Make Us Visible Connecticut, a grassroots organization that advocates for and creates Asian American and Pacific Islander Studies curriculum in public schools in Connecticut. Dr. Hannah Cooper is Professor of Behavioral and Social Health Education at the Rollins School of Public Health here at Emory University. She is the inaugural Rollins Chair of Substance Abuse Disorders Research and directs SPARK, the Rollins Program on Substance Abuse Disorders. Her scientific expertise includes studying the social determinants of drug-related harms with a particular focus on harm reduction and health equity. She applies multi-level, geospatial, and qualitative methods to explore these topics. Dr. Cooper also co-leads TADA, a National Institutes on Drug Abuse funded pre-doctoral program designed to train doctoral students in applying advanced data analytics to studying and ending drug-related harms. Dr. Gabriel Sanchez is Professor of Political Science and the founding Robert Wood Johnson Foundation Endowed Chair in Health Policy at the University of New Mexico. Dr. Sanchez is also the director of the University of New Mexico's Center for Social Policy and a Rubenstein Fellow in Governance Studies at the Brookings Institution. Dr. Sanchez is a nationally recognized expert in survey research and the utilization of rigorous research to inform public policy decisions at the federal, state, and local levels. He's leading several research projects right now focused on the impact of COVID-19 on Latinx and Native American communities, and undertakes work to strengthen civic engagement. Last but not least, Dr. Briana Woods-Jaeger is assistant professor in the Department of Behavioral, Social, and Health Education Sciences at Emory University. She's a licensed clinical psychologist specializing in traumatic stress and culturally responsive interventions. Dr. Woods-Jaeger's research examines social and structural factors that link the experience of child trauma and adversity to mental and physical health disparities. Her work focuses on partnering with communities to identify ways to prevent adverse childhood experiences and to support different systems such as education, healthcare, community-based organizations in responding to the needs of trauma-exposed youth and families. She's currently a principal investigator on research projects supported by the National Institutes of Health and the Centers for Disease Control and Prevention, which are focused on primary and secondary violence prevention and promoting mental health after experiencing trauma and adversity. So please join me in welcoming this wonderful panel. I'd like to start by laying the groundwork for this discussion. The fissures that were exacerbated by COVID existed long before the SARS-CoV-2 virus emerged. So I want to unpack that for a moment, and I'd like to start with Briana. So health disparities existed long before COVID. Can you provide a few quick examples of the way that race and ethnicity have long determined health outcomes?
Yeah, so I think that when we think about how it's long determined health outcomes, like these are, like you said, very persistent health inequities that we've seen. And, you know, the pandemic was, you could kind of expect what we saw in terms of, unfortunately, some of the health inequities that resulted. So when we think about just the way that structural risk factors operate in our society, when we think about employment, you know, who's more likely to be in low wage earning professions that don't have sick leave, that you can't work from home, who relies more on public transportation. When we think about housing and especially crowded housing, all these things that are, of course, going to exacerbate risk from COVID, these are things that have long affected communities of color. And that's, you know, thinking about some of those factors that are more sort of economic. And then, of course, we have all the social factors when we think about racism and discrimination, including things like bias in healthcare. So being able to actually get adequate healthcare when you have an issue. And then thinking about the long history, people talk about mistrust, and I think it's really more mistreatment from the healthcare system that results with people not accessing healthcare. And of course, then we have shortages too, where you just can't access it. So all these things existed before the pandemic, and they result in a lot of other health disparities that we see, like asthma, diabetes, hypertension. All of those things, of course, increase your risk for negative outcomes if you have COVID as well. So there really was, unfortunately, an expected disparity. We knew we were going to see some of these things. And I think the concern I have, and you know, and I think it's promising that people are recognizing it more, is that these things do tend to happen generation after generation, and we haven't figured out adequate responses. I believe that part of that is because we haven't really worked with communities to develop those responses. And of course, you know, there's other political and social structural issues that we need to address. But I think we're at a moment where we really have an opportunity. So I'm hopeful that, you know, we can really start to think about these things again as longstanding issues that we need to address. Of course, that we have the acute crises that we're facing right now, but there's definitely going to need to be a long-term solution.
So since you mentioned the political, I'd like to focus the next question on Gabriel. The polarization we've observed in the wake of the pandemic has also existed for a very long time. Perhaps it was a little bit surprising that it would be applied to a health issue that, you know, should transcend politics, but it clearly hasn't. So can you describe the ways that hyperpartisanship and racial resentment have informed public attitudes about health policy and even inform health behaviors?
Yeah, absolutely. Great question. And thank you for having me. It's a true rock star panel, so I'm grateful for the opportunity to share the stage with folks. So yeah, we'll talk a bit about this. One is the obvious point. The extreme party polarization helps explain who is and is not getting vaccinated, who's been wearing masks, who's doing social distancing. And our statistical modeling, partisanship, even among racial and ethnic minority groups, tends to be a driver explaining those outcomes. So unfortunately, partisanship we're seeing have huge implications through the pandemic. But prior to the pandemic, racial attitudes and partisanship really helped shape health policy decisions that provided key context for outcomes we saw during the pandemic. Give you a couple of examples. Our team's work found that expansion of the ACA to undocumented immigrants, Medicaid expansion through the ACA those are all driven by a perception who is basically who is deserving of that resource of access to health insurance, which is unfortunately highly racialized, right? People think about deservingness of public resources, unfortunately, in this country, often based on the skin color of who we're talking about gaining access. Furthermore, partisanship of legislators and the governors of each state has largely determined whether states have expanded or narrowed access to health insurance before the pandemic and right now in terms of opening up emergency or short-term access points. That's all been highly partisan. And I think this has been key, given that having health insurance at the individual level has been a key factor in COVID-19 infection rates, vaccination uptake, et cetera. So this inequality, unfortunately, is just another example of how pre-pandemic policy decisions directly impacted the disparities that we're seeing on disadvantaged communities.
Thanks. Jason, it's also important to note that racism towards Asian Americans existed well before the pandemic. What did anti-Asian bias and racism look like before the pandemic? How did that manifest itself?
Yeah, thank you. And also really grateful to be on this panel. Thank you for convening this, and it's really an honor to be with y'all. Yeah, it's important to recognize that, anti-Asian racism is also driven by US foreign relations. So you have hot wars, cold wars, trade wars, all of those relationships drive a kind of a sense of Asian Americans looking like the enemy. And so, that has been supported, by, so those conflicts abroad help to support violence at home. And, it's sitting on 150 years of, legal construction of Asian Americans as being aliens racially ineligible for citizenship. These kinds of concepts of, perpetual foreigner, enemy alien, are all, ways in which the Asian Americans have been culturally, politically seen as not belonging. And that one of the other discourses around that is that they represent a kind of social, cultural, and biological contagion, or a relationship with disease. And so, what's interesting about those negative constructions, though, is that despite the political, legal, cultural hostility against Asians, Asian diasporas have been, integral to every phase of economic transformation of the country. And so, it really underlines a kind of founding parable of Asian racialization in the United States, of being desired but also disposable. And so in that crux of between those two, violence is a predictable outcome, and the stresses put on the country, in addition to the pandemic, really was a kind of a storm on the horizon. And so, those were really, like the discourses around Asian economies competing with the United States, with immigrants, refugees, right? The anti-immigrant xenophobic discourse during the Trump administration mirrored almost exactly, late 19th century discourses. And so we have a deep reservoir of discourse and rhetoric around this that is that bubbles up because of the invisibility of Asian Americans, and the need to reckon with that deep history in relationship to other struggles too.
Thank you for that. Hannah, my next question is for you. I'd like to ask you about policing. So the Black Lives Matter movement is now close to a decade old, and concerns about over-policing in Black communities and other communities of color extend back more than 150 years. Your work focuses on the public health externalities of over-policing. So what were your pre-pandemic findings about the negative effects of over-policing on public health in communities of color?
Sure. Thank you so much for that question, and for also kind of embedding it within history. So, the Black Lives Matter movement really took off with the murder of Trayvon Martin. But before that, most of the major uprisings that we've had in this country over the course of the past century have actually had their roots in police violence, right? So here I'm thinking of, like, in 1965, Watts, which many of you may have lived through or have family members who lived through. That was really precipitated by the police arrest of Marquette Frye a couple of years later in Newark. A lot of those uprisings were sparked by different forms of police violence and neglect. And then, of course, from my 20s in 1992, we had the Rodney King uprisings, which were sparked by the refusal to acquit 4 police officers in the really brutal beating of Rodney King. So Black Lives Matter, I think, stands on the shoulders of so many uprisings that have come before. And in terms of the health impacts, I think often we understandably focus on the health of the person who was actually targeted, the health of the person who was murdered. And we don't think enough about the ways that their broader communities are impacted, that there are ripple effects from every single instance of police violence across that individual's families and their broader communities. And I want to highlight the work of Dr. Sewell in Emory's sociology department. I think they have done really groundbreaking work on the impact of police violence that helps us to understand its ripple effects across communities. And just to give you a couple of examples, Dr. Sewell and their team they've analyzed data from New York City, finding that people who were living in neighborhoods where there's been a police killing, those residents of those neighborhoods have much higher rates of obesity, and they also have higher blood pressure. These relationships actually are greater for women living in those communities than they are for men. They've also done just really fascinating work on the impact of stop and frisk on these same health outcomes, finding that people who are living in communities with higher rates of stop and frisk have got higher rates of obesity, high blood pressure, and other cardiovascular health problems. And those neighborhoods are also neighborhoods that are predominantly populated by African-American Latinx communities. I think the final thing I just want to point out is Bohr and colleagues, they've done some parallel analyses looking at states. And what they have found is that in the months following a police killing of an unarmed Black man, that the mental health of Black residents of those states declines. The same is not found for white people, which to me really speaks to the ways that white supremacy and racialized social systems actually distort white people's capacity to fully inhabit our world.
Thank you. I'd like to open this question up for everybody. So how does COVID exacerbate the trends that you've all spoken of before, and how does COVID actually help to shape shift race inequality? So whoever wants to jump in first. Gabe.
I'm not shy, so I'll jump in, mainly because I like the way you framed, Hannah, the ripple effect. And I'll give you one example of that. Early when mask mandates first started coming across various states, we put some surveys in the field and we're asking folks directly who were or were not wearing masks, why or why not. And one of the things that we uncovered is particularly Latino and Black men were much more likely than any other subgroup to report that they were worried about unwanted interactions from police from wearing a mask in public. And that was a constant fear for them, right? That by wearing a mask in public, police officer might engage me, and given the context, I might not be going home today, right? And so despite that, and this is the important finding from that research, despite that fear from generations of inequality and discrimination from the criminal justice system, those same Black and Latino males are more likely than whites, regardless of gender, to say they were still going to do the right thing and wear masks to protect themselves and others. So I think that example to me exemplifies, right, this intersection of the criminal justice discrimination and structural racism and the pandemic.
Right. Others.
Yeah, I could offer another one. One of the interesting things that I noticed is the pandemic worsened in the United States is that Asian Americans are in the healthcare industry, in a really more than beyond the representation in the communities they serve. And so, for instance, we have Filipino nurses who occupy many of those frontline positions, and so we're some of the first to suffer the infections and the disease from COVID. So on top of that, there was also this reluctance of patients to see Asian doctors because of that relationship. Just the hypocrisy of that condition just feels so telling of how deeply as others were speaking so well, Briana, what you were saying about perceptions, and then also Gabriel about access to healthcare, and those inequities, given those and the severity of the pandemic, to then see have that kind of hostile response to a caregiver is really striking.
So I happen to live near a police station, so I apologize if you can hear that. Hannah or Briana?
Well, I think one thing I'll add, because I know I spoke a little bit about that earlier, but I think I do a lot of work with children and adolescents. And so we've been doing some work with schools. And I think that the impacts, again, of all of the kind of disparities that we know before in terms of under-resourced schools, the concentrated poverty, how that really was exacerbated by the pandemic, and again, hasn't been responded to, is something that is really continuing and exacerbating harm. So when we think about virtual learning and how that was a challenge for everybody, those without access to technology, of course, it was a greater challenge, and many of them missed an entire year. Those who had fears of deportation and families that had to work and they had to then work for their family may not have been able to access school. And people weren't sort of tracking in the same way and doing outreach. And so some of the studies that we've been doing, which are much more, community focused, so not looking nationally, but more in specific communities of color, what we've heard is that there's sort of a reluctance to, even when we think about the solutions or what people are doing with resources into schools, to really engage with that, because there's such a gap between kind of how we perceive what's needed and what's really going on in communities. So I think this is something we really have to pay attention to when we think about kids and their development. And then, of course, as Hannah spoke about the mental health issues with police violence, how that's affecting children and adolescents because of the social media and just how it's replayed over and over and over, and there isn't an access to the resources or supports, has really been something that we're grappling with, because that's something that continues to happen. So when we have traumas that aren't, that are unrelenting, it's a very difficult situation to intervene.
So Briana, I'd like to follow up with you, because I want to talk about race and COVID for the next couple of questions. So according to the CDC, compared to whites, Latinx and Indigenous people are nearly twice as likely to get COVID. Black and Latinx people are nearly 3 times, and Indigenous people are 3.5 times as likely to be hospitalized. And Black, Latinx, and Indigenous people are 2 to 2.5 times as likely to die from COVID. So what are the structural factors that explain this type of disparity?
So I think many of the ones I was talking about before in terms of like the economic factors, so when we think about like employment, who's in what types of jobs, what they are able to do in terms of working from home or even take sick leave. When we think about, housing and how that is distributed in terms of where people can access housing, if they're having to move, every month, we've seen a lot of that. Food insecurity. So all of these things, again, that are, pre-existing, really think about how that increases risk for COVID. And then if you get it, again, the access to healthcare is affected by so many different things. So I talked about fears of deportation, so not wanting to go in because you're afraid that you won't be separated from your family. Documented cases of racial bias within the healthcare system, so you don't get the same quality of care. And then the insurance rates, as you were mentioning, Gabriel, in terms of, just having the lack of insurance, the high cost of services. So all of these things, not only are you increased risk of getting COVID, but then having the worst outcomes. And so I think that that's something that, there's been many responses to, but I don't feel like we've adequately addressed it because it is so multi-layered. And it really requires us to understand things from definitely a structural level, but then how does that translate to the community level? And how does the community respond to those structures is really important for us to look at as well.
Thank you. Gabriel, so since Briana mentioned systemic issues, what role does public policy play in perpetuating these disparities? What has government done, if anything, to try to narrow those gaps? And to the extent that they actually have tried to do that, have their policy prescriptions worked?
Yeah, great question. This unfortunately varies tremendously by state. And the simple way to state it is the partisanship of the governor in which you live, unfortunately, drives whether or not you've had positive or negative policies during the pandemic. I'll give you some examples. Here in New Mexico, the state took a very strategic and aggressive approach early on to address racial inequalities. They literally created a vaccine equity task force that I've been sitting on. And that was used to try to prioritize distribution of vaccines, strategies to encourage vaccination among communities who might be fearful of doing so, putting mobile units in to get to rural folks immediately. It was just basically commonsensical policy approaches that absolutely worked, but took that foresight to say, look, we're going to prioritize and use data to address racial inequalities head on. Many other states put aggressive steps in place to open access to relief resources, free access to medical care and testing immediately at the onset of the pandemic, to all residents, regardless of their income level or their immigration status. But unfortunately, this is not a common trend across all states, right? On the opposite end, by not taking aggressive steps to put basic safety protocols in workplaces, having mask wearing policies in place, including what has been surprisingly the most highly contentious mask requirements in schools, many states have put diverse communities in harm's way, directly in harm's way. And finally, I think one of the best examples of this particular issue that played out in the pandemic was the huge variation in how states handled elections, right? Like some states provided easier access to mail voting, drop boxes, other steps to minimize personal interaction standing in the way of voters to be able to prevent the spread of the virus. While other states, as a New Mexican, we always like to pick on Texas, while other states did the exact opposite, forced you essentially to have to stand in line, risk spreading the virus in order to exercise the right to vote. I mean, the craziness of how real that is, I think exemplifies this point. And, fortunately, some states like New Mexico have really role modeled how to do this well. Here in New Mexico, the community that's been impacted the most are Native Americans. I think half of early onset of cases, casualties, all that were Native Americans, who make up about 10% of the population. Our Secretary of State partnered with tribes and allowed them basically to have their own voting location on tribal grounds so that folks would not have to leave the reservation, and didn't allow any non-tribal members to vote in those locations, right? Commonsensical policies we know worked, but unfortunately, again, we're driven almost exclusively by the partisanship of the governor in the state that you live in.
Yeah, I'm actually thinking of sort of like a matched pairs design sort of with Arizona, thinking directly sort of in relation to that. But Gabe, I want to follow up and ask you about the politics of COVID, in particular, thinking about rally effects. So usually we would expect a crisis like this to produce the type of spirit where everyone puts their differences aside to work on a common problem and to help to defeat the virus. But that obviously did not happen this time. So why didn't it happen this time? And, if you could elaborate a little bit more on how those divisions have actually made it harder for us to get control of the virus.
Yeah, great question, right? Our country, in my opinion, was unfortunately so divided ideologically, not even necessarily exclusive to partisanship, but underlying ideology before the pandemic hit, that this rally around the flag effect that we might anticipate occurring never really took shape. And here's a few, at least my 2 cents of why that might be the case. First of all, we have to remind ourselves that large percentages of the population did not believe that the pandemic was real, right? It was either being grossly exaggerated or they literally did not believe it was a real thing. We obviously know where messaging was coming from that helped shape the attitudes of those folks. It was coming from the White House, right? But this makes it very hard to build a sense of commonality around an issue when one side literally does not even acknowledge we have a crisis, right? So I think that's an important context point. Also, our data has consistently found that basically across all aspects of behavior during the pandemic, getting vaccinated, wearing a mask, social distancing, et cetera, the number one reason provided by those that are not complying for not doing so is that it's their right as an American to choose not to do so, right? So when you contrast this rugged individualism, as I would frame it, with the collective good orientation of those who are complying with safety protocols, it's very hard to build consensus. That's that gap in underlying ideology that I'm talking about. Third, I was on a panel last night where this topic came up, and one of my co-panelists suggested that this would not have been as big of an issue if President Trump was not the leader of the nation. I haven't thought deeply enough myself about that to confirm that statement, but I will agree that having a commander-in-chief directly mislead the public for as long as he did definitely made it very hard to build consensus, particularly when our data was suggesting he was the strongest messenger and the most trustworthy news source for a large segment of the country. Finally, this has had and continues to have huge implications for beating the virus. After we address supply and demand issues across the country with the vaccine, obstacles in the way of folks who wanted to get vaccinated but couldn't, we are left with those highly resistant to the vaccination process, a population that we found, despite investing heavily in that, has been very, very difficult to move.
Thank you. Briana, I'd like to come back to you. You study trauma. So a global pandemic is a traumatic event, one that's affected all of us. What are epidemiologists predicting in terms of the long-term psychological and health effects of having gone through this pandemic, and how might they be exacerbated the closer that COVID has come home to you? So if you have gotten COVID, or if you know somebody who was hospitalized or even died as a result of COVID.
Yeah, I think that, it's a great question. I think there's still a lot, the jury's out in terms of what it's going to look like, but there are these projections. And so definitely people are expecting increases in anxiety. So, and more of that generalized anxiety, because there's so many different types of threats, right? There's the physical health threat, there's the employment effect, the economy effect. And so people just having this heightened state of constant anxiety. And for many of them, that turned into a generalized anxiety disorder. Depression is definitely something else that we've already seen really increase. And again, when you think about the losses, so loss of employment, interpersonal relationships, loss of social contact, a lot of the things that we would recommend for people to deal with something like this, they were not able to do in terms of getting out, and seeing people and staying engaged with the things that bring you meaning or purpose. So there's a lot in terms of depression, anxiety, I think people are expecting. And then, of course, when we think about the traumas that, healthcare workers in particular, people are looking at increased rates of PTSD. But also when we think about communities that have been disproportionately impacted by the loss, I think there's a lot of complicated grief, traumatic grief that we're going to have to deal with. And that one is particularly concerning to me because we have less of a really adequate response to that. So there's definitely cultural, spiritual responses. Those have been interrupted. People haven't been able to sort of respond to the losses the way that they would naturally because of the pandemic. And so we're going to have to reckon with that. And then also that this is something, and it's different in different communities and different countries, but grief is something we don't talk about anyway a lot. And so I've heard a lot in terms of just sort of my initial work with communities about where's going to be the space to really deal with this, especially if we're so focused on getting the economy back on track, moving forward. It's kind of like this quick push to get over it, and people aren't going to have enough sort of opportunities to really process. So I think some of those things are definitely on the horizon. We're already seeing increased rates. And then, and Hannah can probably speak much more to this, but in terms of substance use, I think when we think of how people cope with that, so if you can't access treatment or you just don't believe in it, you self-medicate. And so we're going to see, we already are seeing some increases with that. But also if that's just a way that you kind of, a recreation, you can't go out and you're sort of sitting in your home just trying to deal with it, people are projecting there's increases in substance use because of that. And then finally, because people can't access the things that were able to help them before, those that already had mental health and substance use conditions, those worsening to the point of increased suicide rates and things like that. So I will say it's a bleak picture in the terms of some of those projections, but I do feel like what I have seen is that more communities are talking about mental health and are prioritizing this. I think it's a question of where the resources are going to go and how we're going to think about a population mental health response. I mean, definitely the treatments, the individual treatments, the group treatments are important, but we really have to think broader because this was a collective trauma, right? It didn't affect just one family, community. So we're really going to have to think more creatively about how we respond.
Hannah, did you want to add anything about substance abuse?
Sure. I mean, just, not a whole lot more than what Briana, I think, just noted, but that, we're seeing huge increases in overdoses and drug-related harms. And I think that the causes are really multifactorial. So there are, different, multiple different factors are kind of colliding to really escalate the, existing epidemics of drug-related harms. So one of them is changes to drug markets that occurred when we closed our borders. Another is what Briana was just discussing in terms of mental health problems. Another was, the challenges of connecting to effective treatment when most drug treatment programs had closed their doors and had gone online. Not everyone has access to Zoom, right, for example. And so I think that that's really created this constellation of drivers for these epidemics that were already out of hand before COVID struck. And I think we're going to be living with that for some time to come.
Understood. Briana, I want to come back to you and sort of think about trauma, particularly as it relates to children. So kids spent a year out of school without a lot of social interaction with other children outside of their families. What are the long-term impacts? What are you looking out for with respect to that and how and their long-term resilience and how they cope with trauma?
Yeah, I think one of the things we're really looking at now is as kids are integrating back into schools, what is the response and kind of how are they being supported, what's being prioritized. And so, schools are understandably under a ton of pressure in terms of how they're allocating their resources, what their metrics are. And what we're finding just kind of early on, again, this is really qualitative, is that parents and students are really concerned that there isn't a response, again, a recognition of what students have gone through and are continuing to grapple with. This is particularly related to the police violence that has really been, again, it's been happening for a very long time, but the way that kids were at home able to watch that over and over and over is something that is really affecting not only the kids themselves, but their families. And so you think about this sort of, again, community trauma, family level trauma, and then going into schools where, as Hannah mentioned, the mental health effects are different for different racial groups. And so if you have majority white teachers in the school that maybe don't have the same understanding or experience, how they're responding to these kids is something that we're starting to really look more into because there's definitely a gap. And so part of that is really recognizing what kids are going through and then how can we support them both in schools and in community, and how do we really equip schools, communities, including faith-based institutions, really thinking again broadly with resources so they can support the kids in their community. I think a lot of people want to, but are kind of grappling with things themselves. So I think we have to think again, multifactorial, multi-level in terms of how we're going to respond. I do again think the hopeful piece is that a lot of the young people, particularly the ones that I work with, have a high level of mental health literacy. So they can name it and they're ready to work on it. I think we have to get adults there and we have to get systems there, but we do have, I feel like they're advocating for it. So they're asking for these resources. So there's hope, I think it's how do we respond and thinking again about equity, right? And where the resources are going.
Thank you for that. I'd like to sort of end the COVID part of the discussion by talking about vaccine hesitancy. So the news media notes that there's resistance to the vaccine in Black and Brown communities, but in particular in white communities amongst Republicans and evangelical Christians. So, and I'm going to first direct this question towards Gabriel, and if anybody else wants to jump in, please feel free. What has been shown to be the best method to reduce vaccine hesitancy, and how is that targeted based on group identity?
Yeah, great question. I'll try to be brief. I've been doing probably 8 months of my life on this topic, so I have a lot to say, but I'll hit a few points. One is you've really got to think about this in terms of micro-targeting. There's no like one message that works for everybody or one approach. So states that have done the best have really tried to get their hands on as much data to identify for all hesitancy groups what's driving that and how do you overcome it. And a few examples. One is we did a big, massive national sample where we looked at folks that had already been vaccinated and the unvaccinated. Among the unvaccinated, we asked, how do you want to get the vaccine if you're open to it? Overwhelmingly, they said, not in big events. Ideally, set an appointment in advance with a medical provider so it's anonymous, which makes sense, right? These folks don't want any attention. They want to get it and ideally have a lot of their networks not know that they did, right? So that if you had the resources to do it at states, that was highly effective. Other interventions that work well for some subgroups, for example, are you're seeing all the incentives that were put in play. That was a very, very strong finding out of our work, but specifically for young people. Those under age 30 didn't really matter if it was $100 or $500, they were moved by the incentive, not so much older Americans, right? So that's that micro-targeting that we're talking about. And in terms of finally, when we think about populations of color, what I found in our work that was really intriguing to me is it wasn't so much hesitancy about the vaccine and worried about, big picture issues. It was, I've heard that I might get sick. It might be a week. I just barely got my job back. I can't afford to lose my job. And so that's where underlying good, really practical policy of putting more sick leave in place to allow folks to not have to make that difficult decision could have huge implications. Unfortunately, very, very few jurisdictions have taken that step.
So can I just follow up? Because it sounds like a lot of the targets that you noted were primarily focused on communities of color. Were there any messages that were particularly effective in getting white people to take the shot?
Yeah, absolutely. For whites and particularly white Republicans, not really talking about the stuff I just said, but focusing on this is the quickest path to getting businesses open and driving our economy. And this is the quickest path for not having to wear a mask anymore. Those two messages resonated the strongest with those segments of the population. And in terms of an intervention, businesses requiring or strongly suggesting that you should have a vaccine to work, guess what? All those hesitant people that had all these strong underlying ideological reasons, once it started impacting their livelihood, guess what? I'm willing to roll up my sleeve and get a shot. So it's those combination of incentives, right? And some consequences, I think that have been key.
Let me shift the discussion a little bit. So I started off tonight's program by noting that George Floyd had COVID. So Hannah, should we be surprised to learn that George Floyd had COVID? Why or why not?
Sure, it's a great question. So, George Floyd was, I think, 46 when he died, and he was born in the United States, and I think he lived most of his life here in our tremendously racialized social system. And what that means is that he lived within a world where our housing was tremendously racially and ethnically segregated. Our occupational structure is segregated. Our schools are segregated. That means that Black people, white people, Latinx people, we don't actually all breathe the same air. Literally, we do not breathe the same air. COVID is an airborne infection, and what I think we've been seeing is that because of this segregation, we actually can have different trajectories of pandemics within our population. Right, that's happened with HIV, and I think we're seeing that happen also with COVID. So, am I surprised to hear that George Floyd had COVID? I'm not, given that he had lived all his life in this country, and died in Minneapolis, which is, one of the cities with the worst economic inequality, the worst homeownership inequality that we have in the nation.
So it's really important to sort of highlight sort of the life chances that I think you outlined there that are highly circumscribed by race in this country. In your recently published book, Hannah, you describe police violence as a public health issue, and that might seem surprising or even provocative to some people. Can you explain why policing is a public health issue?
Sure. So I want to be really, really clear that by saying that it's a public health issue, I'm in no way making that mutually exclusive with having it also be a human rights violation and a civil rights violation, right? So it exists kind of in all three of those spheres. The Surgeon General, I believe in 1968, so decades ago, declared violence to be a public health emergency. Right, that was really the first time that public health had fully embraced violence as something that was within our purview. And shortly thereafter, we built up surveillance systems to capture different forms of violence. We started to build interventions to try to reduce community violence. We started to address intimate partner violence as a public health issue. What I think my discipline bears responsibility for is that we actually did not deem police-related violence to be a public health issue until a few years ago. We were actually very late to the table compared to the ways that we had mobilized around other forms of violence. And to me, I think that means that we really bear responsibility for the escalating rates of police violence and also of including police killings. From my perspective, I think that the reason why public health did not engage with police violence when it was engaging with other forms of violence, I think that has everything to do with the fact that our leadership is overwhelmingly white, and we set the agenda, and we did not, white people set the agenda, and we really chose not to engage with this incredibly potent form of violence. It was disproportionately killing people of color.
One of the subtexts that was attempted to be used to try to make George Floyd a less sympathetic figure was his struggle with drug addiction. And that's also a part of the story, and it actually ties into COVID susceptibility as well. So Hannah, since a lot of your primary research is on addiction and substance abuse, what's the relationship between addiction and COVID susceptibility? What is the nexus with policing, and how have public health officials been trying to reach out to provide pandemic assistance to help those who are struggling with addiction, particularly in the context of some of their vulnerabilities to the police state?
Sure. So, I think that there are kind of intersecting vulnerabilities. So the first is physiologic, right? So if I am taking opioids, that actually is going to affect my respiratory system, and it may make me more vulnerable to COVID-related health problems that are affecting my breathing. The same, a kind of a parallel physiological phenomenon is true for stimulants, which can have cardiovascular effects. Know that cardiovascular comorbidities can exacerbate the progression of COVID and kind of can increase its fatality. There's also, so that's the physiological pathway or set of pathways, but I also want to recognize the socially created pathways. So because of the war on drugs, because we have as a society chosen to view drug use as a criminal justice issue instead of a public health issue, what this means is that a very high percentage of people who are behind bars or have some kind of history of drug use, whether it's a substance use disorder or not. So recent data suggests that about 60% of people who are behind bars in this country have some kind of drug-related history. And what that means is when COVID struck, anyone living within a facility, a prison facility, a jail facility, was immediately at tremendous risk because they were congregated together. And we know that there are massive violations of human rights and kind of health standards within prisons and jails. So we've seen just an extraordinary number of people die behind bars, and many of them are people who use drugs. And because of the way that we have waged the war on drugs, because I would say one of the purposes of the war on drugs is to create a racialized social system, the people who were dying behind bars and who are continuing to die are predominantly people of color. So there's a socially constructed association between COVID and drug use as well. What's the federal government doing? Sorry, go ahead.
Oh, no, please go ahead.
I was just going to say, what's the federal government doing? What is the government doing? not really enough. I think that we did not build up a strong infrastructure to address drug use as a public health issue before the pandemic. And that's something that is kind of an ongoing curse for us now as we try belatedly to start to do that during the COVID era.
So I want to think about the protests that erupted after George Floyd's murder. So millions took to the streets to protest police brutality and racism, despite the dangers of COVID. I'd like to start with Briana, but Hannah also please jump in. So one, can you tell me from a scientific perspective why those rallies were safer than going to an indoor concert or rally, for instance? And then also, how should we think about those in terms of mental health, in terms of that being kind of a valve release for a lot of frustration about the state of race relations in the United States?
Yeah, I'll take the second one first, and maybe Hannah can talk more about the scientific reasons for so I think in terms of the valve release, so I think that's a really a good way to think about it. So when you think about everyone, all the things that were suppressed or kind of pent up for so long. And for many folks that this was not new, right? For some folks, it's like all of a sudden it's in front of them. For many, this was something they lived in their communities for generations. And so, and what I think is so important is there, again, wasn't an adequate response. So it had been kind of normalized in terms of this is okay to the country, right? Obviously not okay to the families and communities experiencing it, but and so I think when there was an opportunity to really get out there and clearly state it is not okay and there needs to be accountability, that was a really important release. And it was worth it to a lot of people to maybe take some added risk because of COVID. I think most people were wearing their mask. And again, there are things about it being outdoors and all of that I think decrease some of the risk. But I think for many folks, the decision to really be able to stand out there in solidarity with others, right? There was a collective response. Finally, I'm not in isolation trying to like advocate that people look at this issue. I think was an opportunity for people to come together and respond. I think, then again, you want to look at like, what's the long term and, how's that going to translate? Because of the same patterns that we've seen before, when there is an uprising or something happens, if it's not sustained in terms of actual accountability and action, we just kind of repeat this cycle, right? So I think people wanted to be a part of it, and now it's like looking at what's going to happen next, and are we actually going to do something different this time? And that's still an open question.
Yeah, Hannah.
No, I, just think, speaking to the kind of why wasn't there more transmission during those protests, I think Briana mentioned that they're outside, right? And unlike, going to a concert in an open ceiling arena, outside where the protests were, we were really out with, in the sun and the wind. And we know that actually is going to suppress transmission. I think another piece was that, we talked about the politics of mask wearing. So this was a group of people who were mobilizing, who were going to wear masks, and many of them were going to wear masks for their fellow community members, even at potential risk to themselves of having a police officer see them and decide that they were a criminal behind that mask. So that took, I think, tremendous courage. The last piece is that there was, I believe, some compensatory behavior as well. So people, around the time of those protests, people were actually staying home more than they might have otherwise. And I'm not quite sure, I've seen that reported. I'm not quite sure if that was intentional among the people who were going out and protesting, or if that was something that was happening kind of separately in the general population in those cities. But there were, I think, a number of factors that really meant that there was no correlation between those protests and COVID surges.
So thank you for mentioning politics. This sort of sets up sort of the next question for Gabriel. Some people still saw political hypocrisy into the protests, arguing that it was proof that COVID wasn't a serious public health crisis and wondering why it was okay to protest, but it wasn't okay, for instance, to go back to work or to, go to the gym or to attend a Trump rally. So was there any public opinion data about how Americans viewed the policing protests through the lens of COVID, or how COVID attitudes correlate with attitudes about policing?
Yeah, absolutely. And to touch on the last point of the conversation, which is informed me and will help me think through some research that I might be able to pursue. One thing that stood out to me from our data, and we were really tracking this in terms of just civic engagement, political science surveys, is that when we asked folks, did you attend a protest, march, or rally, it skewed overwhelmingly young. So across the population, it was really under 30 and really under age 25 folks who were out there in much larger numbers. So I don't know if that's correlated with virus spread, et cetera, but just note there was some significant demographic differences across the population in attendance. And although there wasn't a ton of work, I'll say, that asked directly about attitudes towards policing protests, we did see a little bit. And what that really spoke to is where folks are getting their information from. And so we ask always in surveys, like, where do you turn to get most of your political content? And you can imagine where conservative-minded folks that already kind of have built-in bias associated how they're viewing the protests and all the political world, that's being reinforced by what they're seeing on the news and how these protests were being presented to them, right, as violent protests, right? And really, I tuned into a number of clips that I saw from the research, basically implied directly, see, this is the hypocrisy that we're talking about in the news. Why do these folks get to go outside and do all these things and we're not allowed to hold political rallies? So given where you're getting your messaging from, right, has huge implications, right, for how you view the political world. And that's not new, right? I thought when I saw this question back to, let's say, the immigration protests that we've seen in previous eras. And the same thing we found in our research when we asked folks, right, you saw these things on TV, what did it make you feel like? Overwhelmingly conservatives that were getting their information from different news sources, they basically, their reaction was, I didn't know there were that many undocumented people in this country. I'm even more resistant to immigrants. So it's unfortunately a repeated pattern where we're seeing reaction to protests instead of gaining sympathy from segments of society that you're hoping will do so. Oftentimes it's exactly as you laid out the question. They see it as an example of what they view as being wrong with the world that's being reinforced by their networks, and more importantly, the messaging that they're getting from the news sources they're tuning into.
Jason, I don't want to neglect the ways that racism and COVID have particular resonance in Asian American communities. So what does anti-Asian racism look like in the face of COVID?
Yeah. So, what we saw, here in Connecticut and across the country was, business avoidance, verbal assaults, physical assaults, and they weren't just random Asian Americans. They were largely targeting elderly Asian Americans, and predominantly women, elderly women. And the vulnerability there, really speaks to the intersectionality of overlapping characterizations, and the really demonstrating the way that Asian racialization is gendered, and that it positions the attackers as really finding the most vulnerable victim, and those kinds of things have were really shocking to a generation of young Asian Americans who grew up admittedly saying that they didn't face discrimination. And for them now to see their grandparents being attacked, worried about their parents going grocery shopping, it's activated a whole new generation of Asian Americans to think critically about this, and also the anti-Blackness within Asian American communities, right? So when we think about the way that anti-Asian violence has really been accelerated and punctuated by COVID, to me, it also connects to a long genealogy of anti-Asian violence that existed prior to this with a different ethnic target, so Sikhs and Muslims after 9/11, right? So if we look at the ethnic diversity of Asian Americans, we see a really long genealogy, continuous in fact, of violence towards Asian Americans. But targeting East Asians, and as some surveys have shown, really, is kind of in a very cynical way, they were sort of next in line, if you could, because of the ethnic diversity, each has a different relationship to U.S. history and those vectors of violence.
Jason, you're also a practitioner. You serve on your state's governor's hate crimes advisory council. You're on a school board. So you get to shape policy to help address the increase of racism against Asian Americans in your state. Mm-hmm. So how do you apply your research and your academic background to your real life policymaking role?
Yeah, thank you for that question. It's something I wrestle with a lot. Being on the Hate Crimes Advisory Council is very difficult for me because hate crimes are not really a great tool. They add penalties to existing criminal statutes if they can prove intent. And so while there have only been 4 hate crimes reported in Connecticut, everyone has a story. So the other problem is it addresses the violence after it's already happened, and hate crimes also, don't do anything for targeted communities. It's also a concern for me that addressing anti-Asian racism with a police response is going to actually bring more violence to communities of color, right? So, there's got to be an abolitionist kind of vision for how to address these kinds of this kind of surge in attention right now, because it has been continuous, right? So what can we do with this attention right now? And spurred by prominent Asian American in the state, Attorney General William Tong, he supported this education effort, and I really think that that, as many have indicated here, it's about connecting with communities, right, and having solutions come up from people who care about their communities. And so I've turned to education as one of those dimensions, addressing mental health through the interdisciplinary field of Asian American studies has been a really strong way to connect people to a sense of history and a sense of themselves, and that lessons from Asian American literature and histories can actually really give people other kinds of narratives and other ways of understanding their world that position them as actors, right, as change agents. And so really I see that as the possibility of using education and with infusing it with a curriculum that is after cultural change, right? That's what we want to see. We want to see cultural change through immersive pedagogies that really center the arts and storytelling.
Thank you for the work that you do. We are about to move into our audience question and answer segment. So if you have a question, please use the Q&A function that's down at the bottom of your screen to write a question, and I will read them to the panelists. If you want it directed towards somebody in particular, please indicate that in your question. Briana, I'm going to let you have the last word since you are the clinician here. So we've all been shell-shocked by the pandemic, some of us on multiple fronts, and some of us in closer ways than others. So what would be your best clinical recommendation to help us take care of ourselves and take care of each other?
Yeah, that's a complicated, important question. And I do want to recognize there's going to be different things needed for different people and communities. I want to pick up on something that Jason just talked about that I think is so important, is really the narratives and really understanding the resilience, the strengths, the assets in community, and having that be uplifted as we're dealing with all this trauma and all of this kind of constant threat and stress. And so I think that for there to be more opportunities, that really requires us to think about curriculum changes and the different narratives out there and how we can really shape those. I also think there's, a real importance of honoring the hurt, and really being able to name it and acknowledge what people have gone through. We are in a society where it's like on to the next thing and, very reactive. And that obviously there's a need for us to be quick in many responses, but taking the time to really acknowledge that and being able to create a culture where it's okay to be hurt and to be working through that. So really thinking about some of the stigma and how do we address that in multiple ways, right? In terms of even in workplace cultures and, maybe taking time off is actually okay, right? I think about our own academic cultures and things like that. But I think really being able to come together collectively, again, because this was a collective trauma for many, and think about what are going to be those collective responses and being guided by community, because I do think there are solutions out there and we have to resource those solutions. But who's making the decisions and how those are really going to be scaled is going to be critical. So, so that was probably a lot of different ideas. So, and I think that there's probably many more. So I'd love to hear what other folks think about that.
No, very much appreciate this. First, let me just take a moment to thank the panelists for their wonderful insights so far. Again, if you have any questions, please feel free to use the Q&A function to submit your questions, and I would be happy to read them to our panelists.
Yeah, I have a question for Gabriel. Being in on the school board in West Hartford, I was able, and also being a university professor, I was able to see two systems try to manage COVID. And I'm wondering, on your research, what could you say, important takeaways from how schools responded to the pandemic, and what were perhaps some underlying racial disparities within schools that maybe dictated particular kinds of responses?
Yeah, great question, Jason, and thank you for your service on the school board. It's important work. I think a couple of things that we found, and most of this is New Mexico specific. We were asked early on, and this I think speaks to, again, I'm always advocating for practical common sense policy. School districts here and the state's overall system came to us almost immediately and said, look, we need data. We need to know what our families are going through. And one of the things that we found out early on is, everybody knows about digital divide and access to the internet, right? And so places like New Mexico that were trying to do things as quickly as possible and trying to help families, they did the right thing by providing, whether it was computers, tablets, hotspots, giving people those resources. But one of the things that we found in our surveys is it didn't always match up with the software required to do distance learning. So again, commonsensical stuff. Fortunately, they asked us to do that early enough where they could fix it. But just think about that, right? Makes perfect sense. You're giving computers to folks which are often older machines, and guess what? It doesn't interface with the software needed to actually do homeschooling. One of the more long-term and unfortunately not as positive results from some more recent research I'm doing with some economists on my team is that finding out who had access to all of these tools, even among families that didn't have high-speed internet at home, we've identified that folks who got access to those resources from their school district basically made up almost the full year of learning loss. Well, unfortunately, those folks that also didn't have high-speed internet at home, but didn't get those resources, they're almost a year behind their counterparts, right? And obviously, right, you framed the question very well, race, ethnicity, and income are highly correlated with A, who didn't have internet to begin with, right? And B, who got access to those resources from their district and were able to employ them correctly to keep up with their academics, right? So that long-term implication, I don't think we'll know the answer to the consequences of that probably for some time, but we're already starting to see ramifications now. Great question.
If I could just follow up,
Yeah, go
I'm
ahead.
sorry,
Yeah, go ahead.
This is interesting to me because what we realized with the folks in our district who chose to go remote, that was it ended up having a kind of character, its composition and demographics that didn't match neighboring districts and even other states. And so those people who chose the remote weren't always the same people in different places. And so, it's a really fascinating study, and I would love to stay in touch and see what work comes out of your shop. So thank you so much.
Absolutely.
We are all about making connections here. I always learn something new at each of these events, and it certainly does help to inform my thinking and my own work about things. We have a question from an anonymous attendee. What are some more research questions that any of you would like to see answered or explored related to COVID, race, and racism?
I'll start things out. Sorry, folks, I'm not shy. One that I'm actually doing a little bit of work on, but love to see others doing is, unfortunately, even great states that have done really well are now trying to focus, as re-election is on the horizon, on everything is awesome. People are back to work. We don't need any more support resources. Unfortunately, our data consistently shows people of color in particular suffered high job losses. Even if they've gotten their jobs back, they went from being permanent, high-paying jobs to not so much these days. They've lost their insurance as a consequence of losing their job. So just thinking about the economic consequences associated with the pandemic that are going to be long-term, right, and aren't going away, right, in the next several months. I would love to see more research done, identifying and shedding light on that challenge and finding solutions, whether that's direct cash assistance programs, whether that's more federal funding, whether that's states. Really, in my opinion, making permanent a lot of great things states did in emergency times. Why aren't we talking about doing that all the time? Right? I think that type of research that's much more long-term focused, I'd love to see more of that.
And just to kind of build on that, I feel like they're, going back to, drug use and the war on drugs, a lot of states really tried to deter people, steer people away who've been arrested on drug-related harms and other non-violent offenses. They tried to steer them away from jails and prisons, right? So they tried to do home incarceration. They tried to have warrants. They did everything they could to keep people out of jails and prisons. And to me, I would love to see that continue. And, there are, I think, a lot of ways to go about abolition. And I think that, the kind of deterrence from jails and prisons may have trickled down into police practices and the ways that police were engaging or not engaging with the public. And to me, I think there might be a lot to learn from the COVID era in terms of how the war on drugs was waged that we might be able to carry forward.
Any other future research topics, Briana?
I was going to say, I think something I'm really interested in. So obviously we've been talking a lot about the pervasive negative impacts of COVID. And I think there's more, research documenting that. But I think there were some things that some people did better in COVID, even when we look at like workplace microaggressions and people that did not have to experience those and actually their mental health improved. And so I think there's some interesting things about, as we look about what we're going to return to, or maybe we don't return to everything. And what are some of the things that we maybe can learn that were better during the pandemic to sort of build on. And along those lines, I think that for communities of color that were denied a lot of the resources that were allocated and had to rely on mutual aid and some of these other practices, like how can we start to understand those and their impacts and really, again, resource those, which is going to be different than how we do some of these like federal top-down programs. So I think there's some interesting questions around some of the things that emerged from the pandemic out of necessity sometimes, but also just kind of the effects that it had on people differently and what we can learn from that.
Thanks. Jason.
You know, one thing I've been thinking about is like teaching effectiveness for anti-violence, anti-bias work. And there's been some studies about like anti-bullying programs, but a lot of them, their effectiveness kind of tapers off after middle school or even in middle school. And, you know, so really thinking about not necessarily even just the content, but the pedagogy, you know, like what are the ways in which teachers can engage students in those kinds of, you know, modeling, you know, conflict resolution, modeling, you know, kind of self-awareness, and, you know, just many of the other issues we spoke of tonight. You know, how do you consider intersectional disparities? Right, like those are things that will, you know, generate, you know, kind of consciousness, but also hopefully empathy, and willingness to for folks to stand up for each other. And I think, you know, when, you know, we see stuff like that, you know, really pay attention and, you know, how, you know, what are some of the not only curricular, you know, content, you know, that we can do, but what are some ways that we need to be training future teachers?
We have another question. This is from one of our fellows, Shari Mackinson. I'm curious about some of the emergency policy changes, particularly monetary payments or eviction moratoriums that were only enacted because of the pandemic. How do we move them towards sustainable social safety nets? I'm specifically thinking about the fact that if they end too soon, we may not get the kind of data to demonstrate that these are good investments, rather than huge budget failures or one-offs that lead to sustained federal debt.
I'm gonna pause, see if anybody jumps in.
Go ahead.
I'll take it. So it's a great question. And as I noted earlier, I'm of the opinion, everything that worked well should be made permanent, period. It's that simple, right? Policy is often made overly complex. In this context, if it worked and it expanded benefits and we're seeing improvements for population, why aren't we making those permanent? The reason for that is politics, unfortunately. So if we think about any of the policies that you referenced in your question, we're already seeing this framed as, these are the reasons why people aren't getting back to work, right? As collectively across the country, we're seeing a lot of people decide not to return for the workforce for a number of reasons, right? It's already being framed politically. It's because these safety net policies are undercutting our work ethic. Again, same playbook. We've heard generations and generations being employed at this period. One really good example that I've seen in many states is, guess what happened when we removed the red tape associated with being able to get access to free lunch for kids? You stopped tracking it, you stopped making it difficult, and you just said, buy enough food, whoever needs to get it, come and get it. Guess what? Food insecurity was markedly different during the pandemic and improved for many states. Why isn't that always the case, right? Those are just not even necessarily changing policy. All it's doing is removing bureaucratic obstacles in the way from people being able to get access to resources that they need. If we figured out how to fund it during the pandemic, guess what? We'll figure out how to fund it if we value it moving forward long term.
Let me just ask a follow-up question to that. So, you know, in September, there were states during the summer that ended additional unemployment insurance, expecting that would force people into work. And I think we were particularly expecting to see sort of improved unemployment rates in September once kids were back in school. And yet we haven't seen that in states that, you know, got rid of the employment supplement and those that didn't get rid of that employment supplement while it lasted. What does that tell us? Or do we not have enough data? Or do we need to wait for perhaps December being the other cut point where hopefully there are kids who now have access to the vaccine for whom their parents might be more comfortable going back to work, like once the children have been vaccinated as well?
I'll jump on that one to start. Please, folks, add to it. I think it's a little too early to tell in terms of like having a causation story or, you know, being that precise. But we do know, right, there's been a lot of surveys done of the unemployed population and what was their behavior shifts in trying to find new employment. There's a whole multitude of factors that are driving people's decision-making, not just whether or not they got those temporary benefits. And I think just being rational, right, we know that those short-term benefits were nowhere near, right, large enough to be able to sustain folks to the point where we could say that's the reason. That's just nonsensical. I will say in the work that I've done on this, that the number one reason was access to childcare, right? Many childcare centers are out of business and are not coming back as a consequence of the pandemic. So we just assumed, right, that like, okay, kids are going back to school, everything is awesome, folks will find childcare. Guess what? A lot of that competition, right, for quality childcare has increased substantially for families. So a lot of folks are making decisions that we know they were making prior to the pandemic. Again, framed the exact positive way that you all with this event have done. These inequalities existed, right? Folks have to make tough decisions. Is it better from our family's financial standpoint for me to stay home or work part-time to be able to be here for my kids, even if they are in school after school or if they're young children, right? Or is it better for me to go back to work? And I think that calculus is different for many families, but I would bet that's a bigger explanation for what we're seeing in terms of workforce behavior than the presence of safety net. I think that just is commonsensical to me.
Great. So another question from the audience. I believe some of the distrust in the healthcare system is rooted in the unethical experimentation on African Americans and other marginalized groups. Do you think increasing the number of minorities in healthcare leadership and clinical positions will reduce disparities?
Well, I think there's some interesting research coming out now that speaks to that. So Rachel Hardman and her group at University of Minnesota, there was a study that came out this summer that looked at physician newborn concordance in terms of race, ethnicity, and found that it actually improved Black babies' mortality. So really looking at an outcome that has been very entrenched. And so I think that's really interesting, right? In terms of thinking about healthcare providers and administration, as was mentioned. And the question that becomes, how do we really start to address that in a robust way? Because we do have such low numbers, but I think that there is more research looking at that exact question, which is really interesting.
Great. Oh, Jason, go ahead.
Yeah, it's sort of, bridging the earlier question with this one, it's made me, think about the ways that the ESSER funding and the American Recovery Plan funding for schools really allowed them to become more kind of full service schools where they, there's not just, classroom instruction happening, but that's where, families are picking up food, they're getting technology supplements, they're getting information about healthcare, they're, finding access to other social workers. This in addition to that, Connecticut has declared racism a public health crisis, and schools, I think, are really well positioned to be able to offer some of those medical services, such as maybe drop-in dental checkups, or other kinds of access, that would bring families into, greater proximity to the services that they need, and that those services should be, should be run by folks who know the community, and that they see themselves represented in the providers. And so I think, that question is really, is really wonderful to try to think of, how to move forward with the things that have that already have that demonstrated effectiveness.
Dave, go ahead.
I'll just say real briefly, I published a piece with some co-authors at Brookings yesterday on this particular topic, and we found, particularly among racial and ethnic minorities, having their own direct negative experiences and discriminatory practices within the healthcare system is definitely correlated with vaccine hesitancy. So that you're dead on with your question. The second part of your question is a more complicated one. I'm a strong advocate for descriptive representation. I published a ton of stuff on that topic over the course of my career. So I want to say having folks from communities of color and those communities in positions of power and influence will change outcomes. But I actually learned this from Abigail Sewell from y'all's institution when she came out to UNN to do some work with us on structural racism, that putting good people in racist institutions isn't necessarily going to shift structural racism. So again, I like all of us, I'm constantly learning, and my optimism about having people in leadership positions, unfortunately within systemic racist institutions, might not be the silver bullet we all hope that it will.
So I want to thank everybody for shouting out our colleague Ali Sewell. I'm going to definitely let them know if they're not on the call. So we have another question from Brittany Frederick, who's another one of our fellows. Brittany says, I'm thinking about how the vaccine booster has further polarized people about the efficacy of the vaccine. I know people in two camps, those who refused to get the vaccine, who feel further affirmed, and those who got the initial vaccination, who feel like they may have wasted their time. How can the government better work with its citizens so that people trust national health initiatives?
I'll start on this one. I've been doing quite a bit of work on this, and particularly in the context of boosters. So the long story short of it is, when you look at the data, the same people who were not hesitant to get the shot the first time, same view about the booster, no big deal. So it's really that underlying ideological hesitancy about the vaccine itself, at least in big national data, that's driving who's open to get the booster. In fact, like we were testing on this before it became part of the federal discussion. A large segment of the population is willing to get the flu vaccine in combo with COVID. And it's intuitive to me, right? If you know anything about vaccinations, you know you don't get a flu shot once and call it a day. You need the booster every year. So I think it's largely driven by people's underlying views about vaccines, period. Not so much about, hey, I thought it was only going to be one shot and I was going to be done. In fact, Fauci was messaging on that early on, that this might not be a one-shot vaccine. We're probably going to have to think about annual boosters, all of those things. So it really is, unfortunately, the same underlying ideological gaps we're seeing in vaccine hesitancy are going to show their ugly face again when we start talking about the booster.
So we have time for one more question. That question comes from an anonymous attendee who asks, and I'll ask this of everyone, if you had $1 billion to spend on an initiative right now, what would it be?
Climate change. I mean, we haven't talked about climate yet, but like if you're not paying close attention to the census numbers, should be very scary to you that you're seeing large migration into places like where I live out here in the Southwest, where there's no dang water, right? So we need to be thinking about climate change, right? If not, we're running out of time. If I had that level of resources, I'd probably put it there.
I mean, I think probably from a public health perspective, climate change. I would also say, putting it into voting rights and kind of eliminating gerrymandering, to me, would give us actually the foundation where we could in fact have the full population vote. And I think if you look at data on the full kind of where the politics are of the underlying population, it is in favor of a lot of social and economic policies that will advance health and advance equity.
Jason or Briana?
Well, $1 billion is, feels like a lot, but, but I think if I did have $1 billion, one thing I'd like to see is a nationwide arts corps. The people that are connecting communities, telling stories, and providing another aesthetic anchor for the future work that we'll all do together.
And I think I'll just sort of jump on everyone. I echo what folks have said and just say that I would put it into the hands of young people to do those things. So I think they're so innovative and there's so much that we haven't thought about that is really ready to be tapped. So I would, all of these things in the hands of young folks.
Great. Well, thank you all for being a part of this wonderful and thoughtful discussion. I think we've all learned a lot from your comments, and we're going to take this with us and we're going to keep on doing the work. So in a virtual space, it's hard for us to sort of, give applause, but please know that we're all doing it. And we want to thank everybody who attended this event. It will be posted online later in the next couple of weeks. And we hope that you can come out to our next JWJI event. So our next public dialogue will be held on February 10th. The theme is going to be Black and Asian solidarity. And we run a weekly colloquium. So our next colloquium is on Monday at noon. For more information, please feel free to go to our website, which is www.jwji.emory.edu. Again, thank the panelists for being here. Thank you for coming and hope you have a great evening. See you soon.